He'll help you then. Good morning, everybody. My name is Jörg.
Are you going to put it up?
Do you want help putting it up now?
I'm connected right now. I should be up.
Nice to have you here, and a cordial welcome to our colleagues from Virginia Mason and Northwest Hospital and other hospitals from the area here. So we're very glad to have you here. It's our habit that we always acknowledge special performances by residents first and foremost. And jumping right into the middle of it, Laura Stahl got a particularly nice note by Lillian Bruce Kaufman.
I was on before.
She was in the ER, seen in the ER by Laura, and Laura did a phenomenal job. In our hand service, acknowledged the great work that you did. And yes, Amanda, I see you back there. You're next.
It's coming.
Our radiologist identified that you did an outstanding job volunteering in a variety of medical things that were not necessarily orthopedic in the radiology suite, and helped us workflow dramatically. So thank you. Exemplified our department's virtues wonderfully. Dr. Himmel gave Kenny Gundel particular kudos. He apparently, and I'm quoting here, amazed me with a sensitive assessment of the patient and did a great job facilitating a very complex patient. He was pleasant to speak with, and he gave basically helpful hints to the patient and his complex social environment. And this is again a very wonderful environment that he created out of a potentially very difficult situation. So thank you again for doing a great job. As we're all coming in, this is a very special morning for us. We're in for a really almost historic treat. We have two superstars of veterinary orthopedics here, who have both contributed dramatically to the field and to our field by treating the most non-compliant patients and sometimes challenging patients you can imagine. Let me start with our guest of honor from Switzerland, Professor Jörg Auer. He was born in 1946 in Chur, Switzerland, and for the R2s here will be a test on pronunciation of and you may not spit in one another's faces if you say that. He went to medical school at the University of Zurich in 1968 and graduated in 1973. And he did an Equine fellowship in Pennsylvania. And this will make Ted Wagner very happy. He has a UPenn tie. He then, and Chip Rout is not here, he would be very happy about the next step in his career ladder. He joined the faculty at Texas A&M and became the equine go-to surgeon in College Station from 1978 through 1989. And during that time, he also was a founding father of the Veterinary Orthopedic Society, and he was then called to the University of Zurich to be their chair. And during that time, he wrote the definitive textbook of equine surgery, which is now in its 4th edition, to which our second guest of honor, Dr. George Bagby, contributed also. Along the way, Dr. Auer was the founder of the European College of Veterinary Surgeons, which is the main sanctioning body for veterinary surgeons in Europe. And he also was very active in the AO, and this is a particular bond, especially for the younger residents. I hope that you all realize AO is this incredible and unparalleled global organization. It's truly interdisciplinary. It combines veterinary surgeons, cranial and maxillofacial surgeons, trauma surgeons, and yes, spine surgeons. I could not help myself for pointing that out. Nobody's laughing anymore. In one large global outfit. So it's a really huge opportunity to kind of network around the world, and what we're seeing here today is one of those network ideas. He received the AO Recognition Prize for his tireless work in the AO community, and last night during a dinner with Ted Hansen, they're both reminiscing of how they started the first couple of AO courses in 1973 and 1974. We will invite a special commenter. It's a special honor to have Dr. George Bagby here, who came from Spokane, Washington, who is another one of those major contributors for spine surgery and trauma surgery. And there are a couple of exhibits that Dr. Bagby was so kind to bring here that show equine surgery and the veterinary surgery in principle. So it's really a great constellation of having these two eminent gentlemen here today. We'll start off with Professor Auer. Jörg, it's a great pleasure and honor to have you here. You wear a nice tie today, I must say.
Yeah, I like yours too.
Good. All right. Here's some water, and you have the podium.
Wonderful.
Look for this. We have Swiss Ricola.
Ricola. Yeah, great. Thank you very much for inviting me, Jens, and it's a great honor for me to be here. And actually, I'm humbled by being invited here. And hopefully, I can tell you a few things that may be new to you. And with this, I go into it and just hopefully we have them all. Can we turn out that thing? So when I say patients that kick, bite and kick, I mean it. Just look at that picture again. It's but let's turn the light down, please, so you can see it better. I think it's yeah, we have different patients, and especially up front should be off. Okay, good, great. Okay, here we go again. It's amazing what they can do, how that animal got that leg out of it and kicked him in the chest, and that guy died, actually. So it's not funny, and you think you're protected and those things. So you always have to be able to get a way out, and he obviously didn't think not that much on it. But nevertheless, there are other things. You know, sometimes when we get a patient, we do not know which patient we should treat. Is it the snake that ate a cat, or should we try to help the cat that was eaten by a snake? When you see here the bones of the cat inside the snake. Other times, if you need golf balls desperately, that's more down in the desert, especially Nike balls, so you can get them out of animals that we have too. So it's kind of a big variety that we're treating with. And if you look at it, what we have to deal with, this is a dog and this is part of a dog. You see all these birds, horses. This is a pinless fixex that was actually developed for human tibias for those motorcycle guys when they grind their tibia into the macadam. But I think it really worked great for cows and for horses for mandibular fracture, because the cows, they have to ruminate. If they can't eat, they can't do anything. So that worked very nicely. So it's just a little bit of application. And again, AO gave us all those toys, and I was involved in it, and I saw what they were treating with them, so we could apply them to what we wanted to do. Like these plates are a little bit used in a different way that they were originally thought for. And then again, you know, an animal is an animal. Now we're looking here at a bovine bone, an outbone. These are two little doggies, and they all have bones, and we have to treat them. They all have fractures. And then we have a very special bone. That's Hausi Willenecker, when he was made a member of a Kansas tribe, Indian tribe, and he was called Chief Big Bone, and they gave him an elephant femur. So that was in a few years ago. So what I like to talk a little bit about, these are some of the topics that I'm going to briefly go into as we go on. And the first part is limb deformities. This is something we are very adamant about it. Now, we all can recognize this valgus deformity. This is the carpus, okay, carpal region. This is the metacarpus. So it's a little bit longer than in humans. And, but obviously distal radial region, we have here a valgus deformity. Now, if you walk around, this is actually in Tiananmen Square, but nevertheless you see a lot of humans with deformities walking around, and especially women. There, a lot of times they have valgus deformities in their knees, and nobody does anything until the problem comes up when they're 60, 80, and they have to have a corrective osteotomy and have to have an implant in there. Well, Synthes is profiting from that, and you surgeon as well, because you can do the surgery. But if you do it at a young age, you can correct it right away, and they don't have to suffer through the whole thing through the year. And if you look at your logo that you have here on your recent publication, that actually means that you're going to try to get things correctly aligned. So I think you should take that to heart and maybe do something about it. And I'll show you what we're doing. This is a young foal. This is actually the first one I did. We used to use temporary epiphysiodesis, growth retardation until it's straight, and then we took it out again. Now, what we developed by luck was a technique where we found, this is again a valgus deformity, and we have a 16-degree deformity here in the region of the distal radius. This is the growth plate. This is the physis of the distal radius. This is a 2-month-old foal. You shouldn't treat 2-month-old babies, I agree, because that's not the point. But what we're doing is we did a inverted T-flap, elevated the periosteum, just closed it up, and then 2 months later, the foal was straight. That's all we did. Didn't do anything else, just a periosteal stripping. Well, at that point, we thought it was we're going to decompress the growth plate because the bone is growing in length. There is a growth plate above and below, and as it grows apart, there may be a lot of compression. That was very basic thinking. At that point, it was mechanical thinking we were using, but it was not necessarily the case. And my research partner, Brigitte von Rechenberg, she came up with a completely different mechanism of action. And if you look here at the physis, you all know how the physis is oriented. This is the epiphysis, this is the joint. And we have vessels going into this region here, coming around. We always found that when we did the surgery, it was always bleeding pretty heavily. So the thought about it is that we have a negative feedback loop, that when we have an injury in this region, we get Indian hedgehog will be produced, and then will be transformed down to the parathyroid hormone related protein or the receptors to increase parathyroid hormone production, and in doing so accelerate differentiation of the cells, and in doing so growing faster.
A question, after you manipulate the periosteum, how do you stabilize it now?
Well, it's just the periosteum. We didn't cut the bone. Just the periosteum we cut. There's no stabilization needed because the bone is still intact.
But post-operatively, how do you put a cast?
We just put a bandage on.
Huh?
Bandage. Light little bandage, just to cover the wound.
Bandage?
Yes. Okay. Anyway, what this does then, and we could find in other studies that we did on sheep, and that it's just in that local area. It's just unilateral on that side, so increases more cells in the growth plate. In doing so, the growth was faster and accelerated this. Now, we used to do pretty extensive surgery. What we're doing now is we did a study on young foals. All we're doing is transcutaneous periosteal transection, no elevation of the growth plate, just the trauma. We just cut the periosteum or traumatize the periosteum in the shoulder region, in the concave area, and it's going to respond with more rapid growth. So that could be done now in an adolescent 12-year-old boy or girl with a valgus deformity very easily, and they could have straight legs. And I think if somebody would take that ball and roll with it, I think that would be great. They do great. They may be even famous one time in that aspect. And what we did also is, and that comes out through research that we did, we have a parathyroid hormone gel, which is a very low concentration parathyroid hormone. We just injected that gel in that region and we had the same result. And that is even less inoculous, so that may be even easier to do. So this came out through research in our lab that we did with the Kuros company. Another point going along the same line, subchondral bone cysts, distal femur here, we have a subchondral bone cyst. That's actually most of the bones can have it, and this is how they look. Sometimes they have connection, most of the time they have a connection with the articular cartilage into the joint. This is how it looks when we look down into a cyst like that is curetted. We can have either a transosseous approach to curetted or an intra-articular or transarticular approach with arthroscopic to curetted. And previously we put in tricalcium phosphate granules. That worked as well. What we're doing now is we're just putting that PTH gel in there. It's a two-component. Put it together and it's going to develop into a gel and it's going to stay in there and it protects the whole cell. And this is kind of how this is going. This is not a cyst when we started out. This is how it looks on the surface. We have a little we have here a connection down into the cyst. And this is now started curetting of the cyst, getting it out, cleaning it out. All done arthroscopically. Get out that this is a membrane that is in here and has a lot of IL-6 and prostaglandin E2 in there. And then once everything is out, cleaned out in that aspect, and that actually enlarges the cyst, that little area. And then we just fill in that gel, start at the bottom and fill it up and move it. And the horses, they do pretty well as we go on. And if you just look at one of these things, this is a frequent part, this is a transosseous, this is the drilling we're doing. We have the arthroscope in there. Here is the original immediately post-op area. This is painful. Horses don't do well. This is the carpometacarpal joint, okay? This joint here, the middle one. And because this is like a wedge, it creates that cyst-like lesion, and sometimes maybe even a fragment. So that's why we put screws across to protect it, especially in the warm blood horses. And that this is 3 months later, this is 6 months later, the whole thing is healed, the animal is sound again. So again, this came out with our research that we're doing, because the research was done for humans to get a bone replacement for defects, to fill up defects in the humans. So we could just transform it to our horses. Just one thing, we have our guest here. This is something that George Bagby and Barry Grant pioneered. This is a typical wobbler horse, and Dr. Bagby is going to talk about it. This is the curve-cut cylinder at 2 places, how it was in, and definitely a very great success. And we thank Dr. Bagby for all his contributions to the equine literature and to the betterment of the horses. Now let's go to fracture treatment. This is how we used to treat the fractures. So this is the thing of the past. We're doing different things. We do not chew them anymore. We have to fix the fracture that the patient can place weight on immediately post-operative. That's one thing we need to do. A horse cannot lay down. It has to put weight on all 4 legs to some extent. We want them to protect it, but they have to put weight on the leg. Otherwise, they founder. It's basically they lose connection between the bone and the hoof. That's like if you're using a fingernail, but you don't have to stand on your fingers. Or on your toes, you use a toenail. You don't have to stand on those, because the toenail is in a horse completely going around. So it's excruciatingly painful. So that's what we need to do. And in long bones, we usually double plate them. We stagger the plates to get the whole bone covered. And another thing, we use screws in all the screw holes, or all the plate holes, basically. That has now lately a little bit stopped with the LCP, but in most cases that's one of our principles. So most fractures are treated with lag screws by far, and some external coaptation. This is a proximal phalanx fracture, a typical one. It's coming down through the sagittal ridge, kind of the groove, and then rotates around the bone, comes in the back, comes up straight. Look at the proximal aspect of the joint in the CT, the cross-section. At the distal aspect, we have just a little tiny sliver like this. And that's where it goes into the joint, and we need to be careful that we get that treated so we can put selective screws according to our configuration. Here I over-drill the screws, I put a washer in to get adequate compression, and the horse went on it, did just fine. This was the lead horse in the circus, in our national circus, and this is the foot where we did the surgery. He went right on back to his work, what he did. Plating, that's just one of them, an older picture. Radius fractures are a big problem in the horse. And as you can see, they have a slight little curve. We're going to come to that a little bit later. It's difficult to get a plate in from the bottom to the top, because if you do this, our screw holes are going to be behind the bone in this plate. So this is one of the big problems. But we did the fraction again. You see, this was an old case, a DCP. We staggered the plates, but went from bottom to top and kind of filled all the holes, put some lag screws across into fragmentary to get a fixation there. And this horse did very fine. Initially, the owner just wanted to have a pet. So this was 8 months later. Everything was healed. So the owner said all of a sudden, it was a Tennessee Walker mare. He said, oh, I want to ride it again. So we just had to we took one of the plates out because it was covering a little bit of a problem with the tendons down here. And then he went down and he could ride it again. So he was happy with this. Now going a little bit into the small animals, and I think size matters. And that's where they have much more differences in sizes. Look, treating this one or this one. This one you can use human implants for adults. Here you have to be a little bit more ingenious on that. So the question, true or false, can a 1.3 millimeter compact hand blade also be used to stabilize a radius and an ulnar fracture? And the answer is yes. This is the fracture we have, complicated. It's ulnar tibia fracture, no, mainly radius fracture. Yeah, there is a little ulnar fracture as well. And this is the treatment. And this is the patient. Now, they're very tiny little bones. And in the Southwest, some of those things, and we have a house down in Arizona, so some of those things are actually, toy breeds if they're not on a leash, they may be gone. And sometimes they may also be lost, okay? So, again, distal radial fractures, classical problem, high incident toy breed dogs. Management is associated with a high rate of complications, delayed or non-unions. And you see here the fracture, and if you compare it to a digit of a human, this is what we're dealing with. So you see, it's different dimension. And the problem is, if you go ahead and put an IM pin in, we just put a little rod in there, that may not work. This has been 9 weeks after the second surgery. They put a cast on, they put that rod, first a cast and a rod on, just nothing heals. So another possibility, the problem there is biomechanical instability because the small bone surface contact, a simple fracture, most of the time have a small fracture gap, they don't heal well, and the cells are being squished between those two fragments, limited envelope of soft tissue, and marginal extraocular blood supply, but also this is a toy breed dog, and this is a regular dog, just put them at the same level. And you see in a regular dog, in a bigger dog, we have much more vascularity than in those little toy breed dogs. So that's another problem, why they don't work well. We can use external fixators or some clamps. These are actually used pretty much quite also in birds. There are prefabricated holes, so we just put them in, put a screw on to hold it, and we can put it. But the clamps are very heavy, and a lot of times too heavy for the dog to carry the leg. So what we sometimes use is PMMA to just unite the little pins that we put in. That works as an inexpensive way to treat it. But the treatment of choice definitely is plating, and that's what we're doing. Another case, a Yorkshire Terrier, 1.2 kilograms. That's a little more than 2 pounds. Okay, maybe 3-pound dog. So not much there, and treat it with a little pin and a screw, and that worked out well. So if you go into comminuted fractures, they're common. Anatomic reconstruction often impossible. Severity of comminution, size of fragments too small, can't put implants in there. Reconstruction by what we're doing is by indirect fracture reduction techniques, minimal invasive exposure sometimes more and more. That's now minimal invasive surgery is becoming popular, and then bridging osteosynthesis. Here we have just 3 portals, a distal portal, proximal portal, and the ulnar portal. And initially, this is the fracture, ulna, radius in the mid part. So initially, put in a rod along the ulna, to stabilize the ulna, align the whole thing, and then put a bridging plate, 2 screws above, 2 screws below, and that's all it was put in. Just slide the plate in, not touching the fracture site, and 4 weeks later the whole thing is healed. Now that works in dogs, okay? Horses, they don't work like that. Cattle can work well again. It's interesting. Both of them are herbivores, but the one lays bone down. It's amazing. The cattle, horses, I think if you want to treat fractures, you have to be a masochist to work with this. No, a masochist to work with it anyway. Now, bridging osteosynthesis in dogs, it's kind of, Don Holtz came up with an idea. So kind of put 2 different things together, and that's what you're going to get. And what he did is an implant combination, either an external fixer and an IM pin, or a plate and an IM pin, makes the plate rod fixation. And the interesting part about it, the good thing, you're going to get the rotational stability with the external fixer or with the internal fixer or the plate, and you get alignment and axial alignment and stabilization by having that in the neutral axis to get stability there. So that's what they're doing in dogs a lot. They're using it, get the pin in there for alignment, get it through the fracture region, and then put the plate on and stabilize it, proximal part and distal part, and leave the fractured area alone. And because of doing this, the hematoma is still there with all the cells, with all the enzymes and all the growth factors in that was not touched. We have stability, we have rotational stability, and they heal very rapidly. This is 6 months post-operatively, nicely healed.
Question?
Yes?
How do you keep the screws? How do you keep the screws from interfering with the IM?
Rotating, angulating them away.
You can see what you do, okay.
Well, you have to feel what you're doing. You can see it if you have fluoroscopy. That's possible. Then you can direct it away.
I think that if they even touch, though, sometimes it'll interfere.
Sure, it can be a battery. Yes,
Yeah,
you're totally right. Yes.
Thank you.
Well, we have a new developed there, a new solution now with the LCP. Just to see if you have the 0 with the plate for increased percent stiffness. If you have a 30% of the medullary cavity pin, we have some increase, but if you have a 50% pin that covers 50% of the medullary cavity, definitely much more, almost 3/4 of the force stabilization more. So it makes a very solid fixation. Here now, that's our newer part too. We're using also LCPs now in this area, so we could just unicortical plates would be another way to go. That's one thing to go. Now, going back to the horse, recovery from anesthesia, not a problem in the dogs. In a horse, we have a problem. And especially because the horse has to get up, and the horse is a flight animal. It does not want to lay down. It lays down if the horse is totally at ease or if it cannot do anything else anymore. So these are the 2 things. So when the horse recovers halfway out, say, hey, I'm lying down, I want to get up. They're getting up way too early. And the problem then is they may stumble around, put so much weight on the fractured limb that the whole thing may break down. So our solution, and actually it's a solution that has been not pioneered, but has also been implemented at Washington State University. It is a recovery pool. Ours is a little bit more sophisticated. It's, I think, the last one they developed. So this is our pool. We put the horse in the water in a sling, and put a Pirelli tire around the neck. It's important, it has to be Pirelli, okay? And now we have a mat which covers actually where the horse can put the head on so it doesn't get the head in the water, because it still has the trach tube in it, and it would suck in quite a little bit of air in there. So, and once the horse starts moving, we can just elevate the floor that is at the bottom. We just elevate the floor. Eventually, it's going to find out I can stand, and then we just get him up. We just so it just has a lift. It being elevated up. We just put a little bandage underneath an IO band over the surgery site, and then put that elasticon on it. Nothing else. No stabilization. Take that all off. Clean it, and then put a sterile bandage on, and then the horse, put him in our recovery room that has infrared, and then put him out, and he walks back to the stall. He has to put weight on the leg. It's just no other way. So this is how it works. Now, early active motion. Now, small animal is not a problem. They can work on 3 legs and sometimes on 2. So it's amazing what dogs can do. Nothing slows that guy down. I definitely like this part here. Anyway, so for the dog, a recovery is not a problem. Early active motion, they can do it very much. In horses, the fracture fixation were frequently supported by external coaptation. We put a bandage on, depending, or a cast for a while for the first few weeks. And then physiotherapy is coming out more and more now also in the horse. And in the dog, the hydro treadmills are being used, so they have less weight on their legs. They can do much better work. And so that works well. And sometimes swimming. A lot of times horses are used for swimming, for exercise, for physiotherapy. They're trained. It's great training for cardiovascular fitness, but not for the bone. So we also have to do some leg work, so they put weight on it. So this is like dogs, some of them swim. So they love to swim in those things. And this is a little on the side now. Some people think they can walk on water, and I think he's very, very fast to do that, walking on water with this thing. Anyway, now high tech, yes, we're going into that as well, and so we are using. We have a C-arm, the Siemens 3-dimensional C-arm. We have in our OR again a P1 fracture. This is a 3D reconstruction of that part. And so we did it in a conventional way, that surgery. And we just put in cortex screws, different areas along the fracture down to see that we have good alignment, good interfragmentary compression. And I think you all agree, if you look at these radiographs, they look very good. But the horse didn't out, but we never know what's happening afterwards. Some of the horses do well, some of the horses don't do well. Now, what we did with these radiographs, we're happy with them, but then we took a 3-dimensional, kind of did the 3D of this, and we actually see where our screws are. We're not so happy with this screw. Doesn't do hardly anything. This screw is better, this screw is not that good. But when we look at the whole thing, we have a malalignment. We have a step in here, which we didn't see on our plain radiographs. And if you take cross-section here, yeah, that's good. But if that's in the middle of the bone like this, it's also at the joint. So we have an incongruity at the joint, so we're not doing the right thing. We're actually having done a very bad surgery. Looks good on that. So one thing is we need to look in there when we do the surgery with the arthroscope in the joint, in the metacarpophalangeal joint, are we properly aligned? Or when we tighten the screw, does it displace it? If you're not perpendicular to the fracture, it may displace it a little bit. And if that's the case, take the screw out, put a different one in perpendicular, and then go ahead, tighten it, and then maybe afterwards you can put the other one in again. But these are things we have to keep in mind. And this is another one where we see a step in here. Here there's a little step there. So this is not what we want to do. So we got into the part, this is the distal sesamoid bone, is in the hoof, within the hoof, a bone about the size like this. And if it has a fracture, like we're seeing here, this is in the hoof. If you want to put a screw across, we have to drill a hole in the foot, in the hoof, and we don't see what we're doing. We're doing it blindly. So this is another part of that fracture. We see it here. So what we're doing, we have computer-assisted fracture treatment. So we have a camera, and we can do navigation with it. And in doing so, we can be actually dead on through the hoof, have a tiny little hole, and just go in, put first our glide hole. This is what we planned. This is for the thread hole. We're putting that in. I mean, the glide hole is already in across the fracture. Now we're coming with the thread hole. And we can see that we're in the middle of the bone all the way, and we can prevent coming into the joint. And if we do this, we have a big problem there. So this is a possibility, and there again, that's when we did the fracture. And this is about a year later. We don't have complete healing, but the horse is at this point sound because we have interfragmentary compression. And over this part, that's where the deep digital flexor tendon comes and attaches right down here on the coffin bone or on the distal digit. So this is one thing that we can do as well, computer-assisted surgery. But we're the only unit that does it. Now, the LCP has really kind of revolutionized our fixation lately. So it is actually the standard plate especially for equine surgeon, but also for small animal surgeon. And it's a stiffer plate because of the locking part, and reduce the micro movement of the screw head within the screw hole, which was a big problem in the horse. What we did for a while is we did plate loading, the opposite what humans did. Humans wanted to get the plate away from the bone because of the necrosis underneath the plate. What we do is actually, they did that at Pennsylvania, and they went ahead, put the plate on the bone. Once the plate was on there, everything was fixed. They took one plate off, put PMMA underneath the plate when it was still in a pasty form, put all the screws in there again, and pressed the plate down onto the PMMA, and then we had basically 100% contact. The good thing about it, and actually that's the main effect what it did, it also filled the parts in the screw hole, in the plate hole, which was oval around the screw head, and in doing so gave the screw head more stability. It was not necessarily maybe the plate PMMA bone contact, but maybe that part was really helping, and that's what we're having now with the locking compression screws that we're doing. So we only put 2 or 3 locking screws on either side of the fracture. The rest are regular screws. Now this is another plate that we're using, a human plate. This is the bent femoral plate of the humans, perfect for the radius in the horse. And if you look at that on the lateral side, now we can come from the bottom to the top with that bent plate. It has exactly the bend that they made for the human, perfect for us. And then what we also did is we changed all our locking compression plates. We have on one side, we have a stacked combi hole. We can put either a cortex screw in or a locking screw. And that's the nice part about it, because the reason is with this on this side, and we wanted to put a locking screw in, this part was hanging down over the joint if we were very close to a joint. So we can go here very close to a joint and don't have that part down. On the other hand, we have the benefit if you want to slide the plate down onto the bone minimally invasively, we can still do it. So all our plates have this, and I think they are doing very well. So you can see this. It has a little bit of an angle up, 95-degree angle down here if you put a locking compression screw in. If you put a regular screw in, we can angulate it like we want to.
Question, is that self-compressing and locking?
It's locking. It's not self-compressing.
It's not, it looks like it's compressing.
Well, that one not, but the other one, yes. But because of the combi hole, here you can get compression. That's self-compression on this one, on this part of the hole, and here, but you have to select if you want to put a cortex screw in here or a compression screw or a locking screw on this side. Either one you can put in, but not both in the same hole.
Gotcha. Thank you.
So again, femur fracture in a dog. Again, just a few rod, and we put the rod inside and put some locking screws, and you can get it by the rod very easily, or you can just use unicortical screws as well. This is a very early part for locking screws. This is a fold that was kicked in the mandible, and it didn't do anything, but the mandible was sticking out to one side. So we went ahead and did an osteotomy and put 3.5 locking compression plate in there. This was the first LCP that was used in the horse, and so we put these on either side. What I didn't do, and that's obviously you have to already recognize it didn't align the mandible with the upper jaw, so I should have pushed it forward, so we have a little bit of a discrepancy here. It didn't bother the horse. He can still kiss his neighbor right now. This is an ulnar fracture in a horse. Again, we're putting these are locking screws, and the regular screws, put an interfragmentary, some screws here to just treat the fracture. And the horse has to get up immediately after the surgery, but then 5 days later we have a breakdown of the fixation, and basically any similarity with anybody in the room is purely accidental here on this drawing. But that's about the temper tantrum that we're having. Have to kind of get in there and doing it. Why did that happen again? So we went in and just put another plate on that side, and then the whole thing went on. This is an unusual fracture. Most of them are just treated with one fracture, but we have such comminution in this place. And there's a lot of pull of the triceps on top, so that's a problem there. Jaw fractures all over. This is a very expensive show jumper, also up towards the temporomandibular joint. And what we put on 3 LCPs in there, and had a fracture up here too, so I got that in. Horse went back and is doing very well in the competitions again. But again, the locking compression, just a great implant. So the maintenance of function again, we can now return veterinary patients to athletic activities after the fracture has healed. That is in sports horses, race horses, racing dogs. They have a lot of fractures, especially in the tarsus, the greyhounds. They can be treated, they can come back in that. For some of them, we can just get them, maintain the patients as for breeding purposes, or in horses, or as companions for severe injuries. And obviously, some of the companions, I think this dog is never going to have a problem breaking a leg because of activity. Clinical research, I mentioned you some of the results that we're doing. I think vets make good partners for research studies if you use live animals, because they know the animals, they know the difference between the species, and it's not, there are metabolic and other difference between humans and animals, and sometimes if surgeons think, yeah, I can do this, they may have some problems, and they may learn the hard way that it's not going to be the right thing. So maybe having a veterinarian at your side to help you doing it. And that's what we got into with our musculoskeletal research unit. We do a lot of studies where surgeons come to us, they want to have a problem solved. We do it, the research done for them. We do everything. We have residents that do it, and we get good results. And because we have about 400 sheep all the time, we do fractures also, or treatment with some goats and some rabbits and so on. Just one of the latest we did, diamondization of the locking compression, locking plate osteosynthesis by using the dynamic locking screw. So this is a screw that has 2 portions that's available now. It's out on the market. And it has an inside core, and there is a little bit, a 0.1 millimeter gap between the core and the mantle. Now the mantle goes into the bone, and this can give a little bit. So we did 3 different studies. One study where we had 4 of these screws on one side, 5 on the other, an osteotomy, no gap. The other one, a gap of 1 millimeter, and then a gap of 3 millimeters, same procedure, same plates, same procedure, all that. And just looking at the data, interesting, group 1, we had initially about 60% stiffness, but at 6 weeks, and at 12 weeks it came up almost to 100% of the normal bone. If we had a 1 millimeter gap, was interesting. Initially we had a stiffer, better fixation in torsion, just not to failure, or actually to failure, that's right. We had 2 groups. And, but it didn't catch up all the way to the other one, and this was the 3 millimeter gap. That was the weakest at 6 weeks, obviously, and then just about the same in there. But kind of studies like that are interesting. And the nice part about it is we like those studies because we always can put something off and you make to our use, like the PTH gel, for example. Works great, and we have good things. So I want to thank you for all your attention. Now, he has got a problem to kick this, but he can definitely run and get it. And in doing so, thank you very much for your attention.
So, Jörg, thank you so much for being here. This was a real honor, treat to have you here. We're here also now, by the way, just that you know that he's very humble, suture anchors, biologic studies on implant versus hosts, those are all some of his works, and he didn't even show us his clamp rod, so there are many other treasures that he's contributed with his work. AO, in the beginnings, was very famous for internal fixation of fractures, and rigid fixation was pioneered by AO. Here to settle a historic argument about compression plating, we have again the eminent Jörg Bagby for an invited commentary. To introduce Jörg Bagby and to have more or less a historic comparison of compression plating, we'll have Ted Wagner introduce Dr. Bagby. Ted. This was the first.
I'm potpourri.
So it's my pleasure to introduce Dr. Bagby. He's been a friend, a surrogate uncle, and someone who really was generated most of his practice here in the state of Washington. Unlike our first speaker, Dr. Bagby,
Can't read it.
You got censored, Ted.
So Dr. Bagby is 80 and approaching 20, and is here from Spokane and flew in yesterday. He has crashed our computer already, but you can see that he's asking questions from the front row, and the Bagby that I've known has done that all his life. And I think there are two major components to a short lecture about Dr. Bagby that might be of interest to you this morning. And the first of those is a condition known as Wobbler's disease. And I'm going to try to do that for you. And the other is the Bagby plate. And we have a new member of our IT department here who's demonstrating his...
No, Aaron is a great guy. This is Bill Gates versus the late Steve Jobs. Steve had a delay virus in there. We did test this before, so I apologize. So I hope at the end of this lecture you'll take a chance to look at the exhibits in the front, because there's some historic...
Actually, while I do this, I think we'll start. I'll pass them out. You can pass them around a little bit and look at them.
Alright, so it's untitled. And the Bagby.
You going to start the video on the...
Yeah, I'll come up to that. Just let me know when you come back up.
So Dr. Bagby and I met last in Bangladesh. And I only tell you that because as a result of a career of patents and major innovation, he was able to finance and has financed an entire hospital in Bangladesh. And here is his quote last trip to Bangladesh. He actually made a curriculum vitae, but did it in a photo way, and this really includes the fact that he was born in Texas, Waco, Texas, and then came to Minnesota. Came to Minnesota and went to, and his stepfather was a veterinarian. George himself went from Minnesota to Philadelphia under Howard Steele and John Royal Moore and John Lockman. That department of orthopedics inspired him, and he ended up at the Mayo Clinic. And in 1956, he completed what was equivalent of a master's in orthopedics. And this is where the Bagby plate was developed, and in all the literature is clearly documented. He then came back to Spokane. He came to Spokane and became associated with a veterinarian there and became involved in what was later the discovery of the Wobbler's disease. This is sort of a formal report, but I think the photos are actually a better way to present him. So I'm going to mention here I'm going to show now this video. Aaron, can I show that? I don't know which side it's on now. So this is a 4-minute review of the very interesting phenomena, and think about it diagnostically when you see it.
Champion run.
This is Secret Intent, son of the great racer Secretariat. He is the product of generations of careful breeding, a masterpiece of grace and coordination, and one of the most valuable animals in the world.
Imagine how his owners felt when Secret Intent suddenly began to lose control of his legs. He was afflicted with a disease known as Wobblers.
The thoroughbreds in this herd have been brought from all over the country to be cared for by a gifted team of veterinarians at Washington State University. One of the horses, like Secret Intent, is a wobbler. There he is. He suddenly collapsed mid-stride.
The saddest thing about a Wobbler's horse is that while he feels just as strong or spirited as his companions, he never knows at what moment his legs will give out and send all 1,000 pounds of him crashing painfully to the ground. Until 1977, no one really had a treatment.
Unrelated.
They're interesting to work with. They generally have really nice dispositions, and I think because of their docility and their kindness, people tend to get more attached to a horse that they know is the wobbler than they would to just a normal, healthy 1 or 2 year old.
It appears and was always assumed that a wobbler's problem is in his leg. The fact is, the trouble stems from a malformation in the vertebrae of his neck. The most common victims are 5 thoroughbred colts who've grown too large, too fat.
In the past, this wobbler horse would have been considered useless and he'd have been destroyed. But now, thanks to an ingenious surgical technique first invented for humans, wobbler has a chance.
The first priority is diagnosis. Once he's anesthetized, the horse will undergo an elaborate X-ray procedure called a myelogram.
On this cutaway section, the 5th and 6th vertebrae, this large catheter represents the spinal cord, and if this vertebrae moved up, it would pinch off the cord, interfere with the transmission of impulses to and from the legs of the horse.
And the X-rays reveal that's exactly what happens. The myelogram clearly shows the lighter section where the spinal cord runs normally, and the darker area where it's being pinched off. Spinal surgery is never without risk, and in this case, the doctors are also working against time. Horses under 10 times the anesthetic a human being can understand, and it's dangerous to keep him out for too long.
The principle of surgery is to fuse 2 vertebrae that are pinching up the cord into one long vertebrae, an extension. And we merely take out and drill out the disc space between the 2 vertebrae.
This is the Cloward technique where they used a drill.
Because we don't want to damage it. After that hole is drilled, then we place in either a bolt or metal plug of larger diameter, so we put pressure on each side, and it thus causes immediate stabilization of the vertebrae.
The plug now being pounded into place will act just like a doorstop to keep the vertebrae from moving. The plug isn't made of bone, it's a badly shaped tube of metal. And there it is. Only 5 years ago, this horse would have gone to a slaughterhouse. Now he'll be on his way home. What we do for him is take him from a hopeless situation where they have to be destroyed to leading a productive life. Now, this might be just as a pleasure for us or as a breeding animal, but most of the people that bring their horses to us are very pleased with the results, being able to take home a horse that can live out a normal life.
So I share that with you today, but I also want you to go on to see the positioning of these horses is, several tons sometimes to lift them. This is the position that you have to operate on. This is the rehab that has to begin immediately. And then I want to speak to the ultimate outcome study. Now, we do a lot of outcome studies that we don't understand when we get all done. So this one is, could he at $50,000 a colt? Okay? So this has to do with breeding. And and the answer is yes. Seattle Slough bred for 50 colts. And so the success was in the outcome well measured. So and each of those is 50,000, and Dr. Bagby reminded me this morning that some of those went at 100 or 200,000. And racehorses have to be bred this way. You can't do artificial insemination or anything else. The owners have to be present. And so this is how that was developed. So I wanted to speak quickly to the Bagby plate. This is 1977 in a review at Mayo Clinic. But in 1956, Dr. Bagby had the idea from a door on the back of his house that when he tightened up the screw, the door came trim. And when he looked at it, he realized he had an oblong hole that he was putting the screw in. It was that observation that led to the Bagby plate. And the compression was born at that time. All of this was published in 1956. And it was his professor at Mayo Clinic who said, don't bother with that patent. It's not that good an idea. And so what went on, these are the pictures of the original Bagby article, and they show you the compression and how he did that. This is the plate that I'm passing around from 1956. This had the outrigger on the end, and as you tightened it down, the oblong tapered hole would allow the compression to occur. And so with that, I would like to invite Dr. Bagby up, because I think Jens has a real question about this. George, can you come forward? Can you come up?
Oh. Sure.
Yes, come on up there. George and I have traveled a lot. I know him pretty well, but he has a little trouble hearing. So Jens would like to ask you a question as a professor. Okay?
Yes, sir.
So George, who deserves the credit for the compression plate then? Who designed it first? Was you or was it AO?
For Christ's sake, I did, but I didn't make any money on it. I think it was a Swiss, some other outfit came in and patented it, but we were able to emasculate it. You know what that word means, emasculate? Take the power away, but we couldn't take the patent away, per se, you understand? So some other companies could come in and use the plate without paying the guys that patented it any money or me, you see what I mean? And anyway, that was, I didn't really make any money out of it, but it just was, I was just proud to contribute something without making any money. Can you imagine?
Yeah, I think you did all right with your wobblers. You have to have a lot of consolation that spine surgery saved the day because you did a lot of good for spine patients. And there are a lot of trauma patients of equine nature or human nature that thank you for your contributions.
Yeah.
I hope that kind of emotional thank you is a little consolation for you. Okay? And just for the record's sake, and Ted can speak to that, in the AO manuals, your name is mentioned as the godfather of compression plating. Is that right, Jörg?
Okay. Thank you.
So with that, we'll conclude this morning's historic gathering of our visiting Professor Jörg. Do you want to come up?
Do I have a
Ted, do
chance?
you want to say anything about the history of compression plating, since you were there in the early days?
Do I have any chance to comment?
First of all, this is the man from Spokane who's speaking. Ted Hansen.
I was Steve from Spokane also. I came to the Shrine Hospital in 1967. And George was there, and I learned about this, and I used some of the Bagby plates early at Harborview before we did the Swiss equipment. And George, I don't know if you remember, we brought you to Sun Valley to an AO course to talk to Perrin and the Swiss at that time in about 84.
Do you remember going to Sun Valley for a course on AO back in what year?
84.
1984.
At the what organization? American Academy?
No, you came to an AO course in Sun Valley.
It was a Swiss course. AO course.
Yes, I remember that.
I brought you there.
Yes, thank you.
So, do you want to say anything else?
Yeah.
No, so I invite all the residents and fellows to come up here. Dr. Bagby has a couple of his things here and shake his hands and take a look at what he has brought along, and Dr. Stadler will be up here also. So thank you for being here this morning.
Oh.
It's a real honor.
Thank you.
It's a historic handshake here.
Thank you.